Hi, everyone, and thank you for joining us today for the Addiction, Medicine, in the Time of COVID-19 webinar. Today, we're going to hear from Dr. Ginette Poulin, who will explore the underlying issues with substance use disorders and help attendees to understand the complexity in treatment from an evidence-based lens. The webinar will also focus on the impacts of COVID-19, withdrawal considerations, and advancements in delivery of care during these uncertain times, including the rapid access to addiction medicine model. First, some housekeeping items. All lines will be muted during this call to ensure sound quality. Please make sure to also turn off your videos. We will also be recording this video and will be posted on our website at a later date. We will have approximately 10 minutes for a Q&A at the end of the webinar, and please submit your questions directly to me during this time. We will take as many questions submitted as time permits. Any questions we can address will be forwarded to Dr. Poulin directly for reply. Now for our introduction. Dr. Ginette Poulin is a family physician and a registered dietitian originally from Thompson, Manitoba. After having ventured to various provinces and countries to pursue her studies, she's returned to her home province where she is currently practicing medicine in a variety of settings. Experienced in both rural and urban healthcare, she delivers health services through emergency, hospital, clinic, and inner-city house calls. She has special interest in international certification in addictions medicine, offering services in opiate replacement therapy and residential programs. She serves vulnerable populations, including those that reside in the inner city and marginalized populations provincial-wide, along with those suffering from mental health and addiction issues. She has taken on leadership roles in medicine, serving as medical director at the Addictions Foundations of Manitoba, co-lead for the provincial Rapid Access to Addiction Medicine clinics, as well as the director of the Mentorship and Clinical Enhancement Program for international medical graduates at the College of Medicine at the University of Manitoba. She is involved in national work on substance use, serving as the Prairie Node Clinical Lead for the National Opioid Guideline Development for Opioid Use Disorders with the Canadian Research Initiative for Substance Misuse, a branch of the Canadian Institute of Health Research. Dr. Poulin is also a co-author for the Management of Opioid Use Disorders, a national clinical guideline. She advocates for the vulnerable and her patients' needs with positions such as co-chair of the Manitoba Provincial Opiate Replacement Committee and as a board member of the Main Street Project and the Canadian Mental Health Association. She is an expert consultant and speaker in addiction medicine at the local, provincial, and national level. I'll now turn it over to Dr. Poulin to get started.
Hello, everyone, and thank you, Nina, for the lovely introduction. I hope no matter where you are across the country that you're welcomed with sunshine today. And if not, even if so, I do hope that you will take away at least one or two good learning points that I'm going to share with you over the next hour in regards to some of the work that we're doing in addiction medicine in our healthcare system in Manitoba. Just to ensure, I wanted to share with you that I have no commercial or financial relationships or interest with any pharmaceuticals or other companies. And I always say my only bias is I'm pro-education, and I really hope that you can take away at least one thing from today. So what I thought we'd review is kind of the background about substance use disorder, talk about some of those underlying factors, some of the key tools that we use to assess, to treat, and to manage, and as well as the rapid access to addiction medicine model. So if we take a step back and we think about addiction and we think about that as we know it in each of our own personal capacities, we probably all have our own definitions of what that means. If you were to look up online, whether on the internet or into resources, I'm sure you could find a plethora of definitions, as I did when I certainly looked those up. But I thought it's really important that we talk about some consistency, and I share with you a little bit what we're talking about when we think about addiction from the health perspective. So first of all, certainly wanting to reframe addiction in the context of it's not a moral decision or failing on the part of an individual, but really a rather complex biopsychosocial notion that has impacted someone in their lifetime, and certainly those within their their family unit or their gathering. And so when we look at one of our reputable sources, which is the American Society of Addiction Medicine, they have defined it as the addiction as a treatable chronic medical disease involving complex interactions among brain circuits, genetics, the environment, and an individual's life experiences. And I think this really depicts quite well some of the complexity behind addiction. If addiction were that simple, we would have a lot of solutions today to fix the problem. And I think what's really important is so that we can get the right resources in place to help individuals in all of that complexity, and see we can deliver better care to Canadians. So for purposes of the healthcare system, we use what is called the Diagnostic and Statistical Manual of Mental Disorders, the 5th edition. And when I have a patient in front of me, these are the 11 criteria I look to make that diagnosis. And so what you'll note is that across this spread, you'll notice 1 to 4 is a lot about the use or how the individual is using that substance. So, they have the cravings, they're requiring larger amounts. They've tried to cut down, but they can't. The cravings are too strong. They're spending a lot of time procuring that substance. And then you'll notice that within the criteria 5 to 9, we're talking a lot about some of the social and harmful impacts, such that people are unable, regardless of their efforts or regardless of some of the harmful consequences they've experienced. And then 10, 11 are really a lot about some of the classic symptoms that are experienced when associated to the substance that people use. So an example would be with opioids, individuals who experience a typical opioid withdrawal associated with that substance. And so when I have a patient in front of me, we look for a minimum of 2 of these criteria to hit a mild substance use disorder, and then about 4 to 5 for a moderate, and then above 6 as a severe. So this is my imagery to kind of demonstrate some of that complexity behind some of these diagnoses, and certainly the areas that we need to delve into with each of the individuals when they come in for assessment and treatment. So when we look at all of these domains, behavioral, environmental, the biology, the social, the spiritual, the psychological, the genetics, all of this envelopes around our individual who's using substance and has those impacts. And particularly, we have COVID, which is placing like another little bit of a cloud around all of this. And so very important that we're addressing all of these issues. I can't talk about addiction without talking about one of the most important impacts, and that's stigma. Unfortunately, this has been something that has plagued the world of addictions for probably its whole entity or time frame or existence. In saying that, I think it has real importance that we acknowledge it, we acknowledge our own biases, we acknowledge the individual, the system, and the societal levels of these that come into play, not only in interactions with individuals, but also in our supports and how we advocate and how we move forward. And if you haven't seen some of the impacts firsthand, we know, and I'm sharing here again, courtesy of the Addiction Society or American Addiction Society, Addiction Medicine, only 1 in persons with a substance use disorder actually receives treatment. And to me, that's quite significant, given that I see people who report that their own self-stigma or the stigma that they experience or the shame or the guilt around their substance use disorder impedes their ability to come access or continue with care. Whereas if we compared that to any other chronic disease, such as diabetes or hypertension, we know the stigma does not exist to that level. So why is the stigma this impactful? I think there are many reasons, and one of which is the challenge of understanding what is all going on in the brain, and all of these parts that I talked about, from the biology to the psychology to the environment and the genetics. And so what I'm sharing with you here is actually Rembrandt's depiction of the first anatomy lesson with Dr. Nicholas Tulp. And this is really to help us to understand that in dealing with medicine and addiction, it's really that art and science to help deliver the best care we can. And while addiction has been around probably as long as most other areas of health and medicine, it doesn't have the understanding to the level that we might of, you know, the heart, the lungs, or our bones. And so what you see to the right of this screen is certainly some of the imaging in more recent studies that show some of the differences in brain anatomy over time with substance use. And so as I go from top to bottom, you'll see the cocaine, methamphetamine, alcohol, and heroin, all of which impact in an important area of our brain that helps manage what we call the reward pathway. And so those are changes in dopamine uptake. And I'm going to help show that on a little bit of a different level. Before I do that, I just want us to realize that there are multiple things happening inside our body and our brain when we use substances. Certainly there are impacts from multiple chemicals and hormones. Here you'll see that in particular, I'm sharing with you some of the key components: the noradrenaline, the serotonin, and dopamine. Serotonin, a lot affecting our mood, our impulsivity, our memory and obsessions and compulsions. Noradrenaline with our alertness, our concentration and energy. And again with dopamine, that reward, pleasure, motivation, and drive. So as you saw in some of those images, and certainly what we know all substances is they impact that reward pathway and that dopamine uptake. So if you permit me to kind of share a little bit of, or describe a little bit of what that actually translates. So if you can see my cursor here, you'll notice that in this important area that controls a lot of what makes us feel good. So our response to whether it was a hug from our family member or something that we succeeded at school, we'll get a surge of that dopamine release. And what happens with substances is it releases different amounts of that dopamine release. It brings that euphoria, often to levels different than much of the normal day-to-day functions are. And over time, because it becomes overstimulated, what happens is there's a little bit of a dysfunction of that pathway, and it no longer works in a way that people can appreciate some of those normal day-to-day happiness or pleasures. And to help show some of the distinguishing levels of surges of dopamine, I'm going to share for you a little bit of an understanding of the percentages of increase in dopamine release with various day-to-day and substances that we have in our world. So here you see a cheeseburger, which releases about a 50% increase in dopamine. Yes, sex increases at about 100%. Nicotine, you'll see at about 150%. Morphine, about 250%. Cocaine at about 300%. And then methamphetamines, a whopping 1,100%. So again, we don't have the precisenesses of all substances, but we do have an understanding based on some of the more recent research what this does. So you can, in seeing this, appreciate some of the differences that do exist with the substances. So while this is going on in parts of the brain, we also have the impacts of how each of the categories of substances With stimulants, they affect our central nervous system. And when we think about opioids, some of those mu receptors, again, pain and euphoria. And certainly when we think about alcohol with some of that central nervous, the GABA receptors, we'll talk about each of those categories very momentarily as it applies to treatment. But again, a really important study that came out to kind of help in adjacent to some of that biological occurrence is some of the historical environmental impacts. And I want to share with you what is known as the ACE study, or the Adverse Childhood Experiences Study, which really was a large-scale longitudinal that looked at the relationship between the individual and the family environment in terms of trauma experiences and how that translated into adulthood. So what they did was they explored 10 measures of trauma, so 5 on the personal level, being physical abuse, verbal abuse, sexual, physical neglect, and emotional neglect, as well as some of the family impacts, perhaps a mother who was a victim of domestic abuse, or perhaps a father who was incarcerated, or a parent who struggled with alcohol, and how each of those impacted the health of individuals in adulthood. And really what they saw is the more of these 10 factors that an individual had, the more likely they were in adulthood to experience a chronic disease, including cardiac disease, hypertension, mental health, and addictions. And so one of the threshold numbers is 4 or more, but I think this is really important when we think about screening and testing. And also, we keep that kind of in the back of our mind in the COVID context in terms of how COVID might impact the environment. And one example, certainly that we know, is that some of the domestic abuse has gone up. And so if that's gone up, how will that translate for the future of some of our individuals? So really, I want to remind us that substance use disorder affects us all. As I say, no one is immune to addiction. The prevalence in Canada sits around the 20%, or the 1 in 5. You've probably heard many of the statistics on the Health Canada level. About 1 in 5 will have a mental health or substance use disorder. And so really keeping that in mind. Again, I would maybe challenge that it actually might be an underestimation, given the fact that the stigma does impact people's ability to disclose or access treatment or care. It's very complex and requires that multifaceted approach in assessing, treating, and diagnosing. And really, this is a time, particularly in COVID, where we're really challenging ourselves to think differently about how we move forward with addictions. And so when we think about the climate right now, some of these are the key factors that we're seeing that are impacting changes in substance use for in their personal setting. And I will say that there isn't a blanket statement that can reflect that applies to all. We are seeing quite a variability, and I'll share with you some of these that we are seeing. So certainly with the isolation and community restrictions, that does impact not only the individual's ability to go out and either procure or access a substance, but also those of dealers who might not be able to enter into community where they supply. There is certainly that changing climate of accessibility. And so as an example, here in Manitoba, particularly in southern Manitoba, we were seeing a lot of methamphetamine. And over the last month and a half, due to the shortages of the international importation of some of the derivatives of methamphetamines for that production, we've been seeing a little bit of a drop in that, and a lot more opioids entering into the scene currently. Certainly when we think about the life situations of individuals, many are experiencing job losses or uncertainty around perhaps their job or their family unit. There's stresses on all levels. What does the future bring? How will COVID impact us in a year to 5 years from now? What does this mean for my family? Certainly people are isolated, whether they're isolated alone or within their family unit or with friends. Some unfortunately have not been perhaps in the same country as their friend or family member. So all of those things are certainly impacting, as well as the mental health issues and anxiety, depression, paranoia. These are things we're seeing on a daily basis. And those who might suffer from those are experiencing increases in some of these symptoms. So not inclusive, but certainly some of the impacts. How this translates in terms of some of the substance uses, they might be consuming more of a particular substance. It might be that they're using a different substance just because what is accessible. They might be limited to what is around them and thus had to change their substance consumption. And certainly when we think about the societal level, whether stores or restaurants have closed down, so access to alcohol supply might have changed. Hours of accessibility to some of these stores has also impacted that. And so perhaps it also could also be that someone is at home and now they're working from home, and so they're drinking more because they don't have to drive to get out to get a drink. They don't have to worry about driving back. They're not worried about people around them judging them. So that might impact lots of factors that we're learning about during this COVID time. And again, it could mean that they're withdrawing from their substance or an increased risk of intoxication or substance-related harms. And so unfortunately, I think recently I'd heard on the radio that while they thought we would be moving towards more COVID babies, the reality is some of the numbers and early numbers that we're seeing are actually showing that the rates of domestic abuse, or at least calls from the police perspective to respond to domestic abuse incidences have increased. That alcohol sales, although a little bit variable throughout the nation, have been changing as well, and certainly on average have been going up in percentage. And certainly the mental health and social distress, safe or accessible housing during this time, particularly those that are homeless and don't have a home to isolate in. And again, these are not inclusive or limited to this, but certainly some of the important impacts we're seeing. And again, during COVID, stigma still unfortunately is in existence. And I really enjoy this photo. I think it shows quite well the coronavirus, or i.e. our coronavirus here amongst the rest of the substances experiencing stigma. And so when we think about how we move forward with this, on a day-to-day basis, but also during the time of COVID, we really need to strengthen and unite together our approach. And so that includes family services, legal services, education, medical, mental health, social. And I really think the National Institute on Drug Abuse has a great image here that shows how successful treatment programs really have really embraced and encompassing all of these components. And so what do I and other of those working in addictions care during COVID do? We have, certainly when it comes to our management approach, we really have kind of these 4 categories, which I'll go through in terms of addressing part of that issue. And so really we think about identification, which includes the screening and brief intervention. Certainly harm reduction is a layer through all of this. We think about doing good assessments in regards to their substance use. We talk about reducing some of the harms for intoxication and withdrawal management on this more urgent basis. And then we're thinking about longer term treatment, which embraces from pharmacotherapy, psychosocial supports, harm reduction, and that continuing reassessment to help individuals as they move up and down in terms of levels of severity with their initiatives that Manitoba has adopted and has been essentially in effect for just over a year and a half, but really has been primordial in responding to substance use and COVID is the rapid access to addiction medicine clinic. And we have 5 clinics currently located throughout our province. This is really a model that has been borrowed from the Ontario RAM clinic. And so we certainly appreciate all the help that our fellow Ontarians have been doing with this model. But really what is unique with this comparatively to many programs within the system, not only for addictions, but for health services in general, is that they have the capacity to self-refer. It's really a walk-in service. And so when we think about that and what we know about addictions medicine in terms of meeting individuals where they're at, this really is a important concept in helping to match that need or meet that need. And so individuals can walk in from the street, they can be brought over from the emergency department or clinics or walk-ins or from the withdrawal management services, from primary care centers, from addiction programs, and really have that ability to be assessed and treated by a addiction medicine expert team, which includes a physician or nurse practitioner, a nurse, and a counselor who really help to identify, assess, and make a treatment program that really is consistent and matches what the individual needs. And I'll walk through again what that actually entails. So when we talk about the screening and identification, we know that having that earlier intervention is really, really critical. So this is something that I would say, no matter where you are in Canada or in the system that you work in, really keep this at the forefront, because if you can open the door to someone, help them to self-identify or access care where that can be identified, that could certainly lead to less negative outcomes in the long run. And so here you'll see a pyramid of risk. When we think about what we mostly see in the system is that red kind of 5% where there's a lot of that high risk use. Certainly we see that because of the harms associated. But we really want to ensure that we're looking at all of these levels and we're matching, so whether it's more risk or harmful use at times or the low risk use, we continuously ensure that we're screening, we're identifying, and we're matching appropriate services to that. And so some of the tools that you may be familiar with, certainly D-Frames, which is a guide to help move towards change. And so that frames is part of motivational interviewing, where we look at the feedback, responsibility, advice, giving menu of options, empathy, and self-efficacy. And then when we think about brief intervention, certainly trying to move people forward in stages of change. We think about those 5 A's: ask, advise, assess, assist, and arrange. So some of you may be experts of these if this is what you do in your everyday, but if not, those are some of the tools that we do use. When we think about the assessment, for example, in clinic with medical services, taking a very extensive substance use history, which includes all categories, when they started, when they last use, how do they use, what is their pattern of use, what route of use do they use, what have been some of the past complications they may have experienced from their use, what are some of the treatments that they have engaged in the past, have they ever overdosed, have they experienced seizures, what current comorbidities do they have, like HIV or hepatitis, what is their pregnancy status, how that might be impacting, do they have any legal issues or financial issues, and certainly what has been involvement of things like CFS or apprehension of children in their situation or their family life. We look at their clinical presentation, which would be very similar to most other encounters in a clinic, as an example, reviewing their vital signs, their cardiac, respiratory, head-to-toe assessment. We particularly focus on safety of the individuals. We look at some of for the sequelae, so whether they have abscesses. Many of them, again, feel lots of shame. They don't want to admit that they've got, around their injection sites, infections that are brewing, the track marks. And so we're very sensitive about how we approach that, but really important that we are reviewing those. And then we use some of our tools, which I'll briefly share with you, that help to assess in particular the degree or severity of withdrawal, which helps us in our treatment approach and our pharmacotherapy and planning. But all of that, again, is really in the context of the goal of the individual. And so that is crucial, because what does that individual before us want, and how do we fit that safety, hence harm reduction, really important. But then again, matching the programs and some of our care, including the pharmacotherapy and psychotherapies, to help the individual meet their goals in the context of safety. So when we think about withdrawal, some of our two key components are opioids and alcohol. And here you see what is known as the COWS, or otherwise the Clinical Opioid Withdrawal Scale. And this is a measure of various classic syndromes that we see with opioid withdrawal, including things pulse, sweating, restlessness, pupil size, bone or joint aches, what we call rhinorrhea or runny nose, tearing, GI upset, tremors, yawning, anxiety, and irritability, and some of that goose flesh. We score this, and that helps us to initiate treatment, to plan our doses of treatment, and then move them into appropriate supports along with that, which could include things from detox and then into treatment from there. Certainly when we think about alcohol, one of the classics is the CIWA. In hospital, many use the MINDS protocol, but this is the Clinical Institute of Withdrawal Assessment for Alcohol, and use the revised version. Here again, you're looking at particular areas of nausea and vomiting, tremors, sweats, anxiety, agitation, either tactile, auditory, or visual disturbances, headache and fullness, and orientation, which all, again, help us to determine this degree or severity of withdrawal and how we might use medications to help stabilize that, or require them to go in hospital for treatment. And from there, also managing them in the community aspect. One tool that we use to predict if someone is perhaps still mildly under, it hasn't gone in withdrawal, we look at what is the PAWS, or Prediction of Alcohol Withdrawal Severity Scale. And again, these are factors that we look in the past history that help us to determine the degree of risks of the individual who may go into withdrawal in the future. And if we are planning care around that, we might want to hospitalize them. So a score 4 more on the PAWS would probably warrant a hospitalization if we're going to look at detox. So again, this is the algorithm that walks through that. And again, as many of you might be aware, when we think about intoxication, certainly with opioids, we've been seeing the rates of fatality across Canada, which averages about 11 to 12 deaths per day due to opioids alone. And so over the past few years, this has become quite a significant tool in helping to reduce fatality, but also engage and provide opportunities for people to start entering into care pending where they're at. And so here you'll see from Health Canada how to recognize an opioid overdose. So some of the symptoms that we're looking for, people's change in respiratory rate, their breathing slowing down essentially, their lips may be turning a little bit blue, really not arousable, they might be confused, they might be dizzy, difficulty staying awake. Obviously, they might have some of the paraphernalia around them from their use. Again, we really reinforce that people need to call 911 for help if they have access to this naloxone kit. And this is something that we offer to individuals accessing care in the RAM clinics, as is elsewhere in public health, but certainly so that way they can have that teaching to use that with their friends and help reverse the effects, but also again reinforcing that naloxone is not a permanent or long-term treatment, really helps the immediate reversal effects. And so we need to ensure that that is part of a larger education strategy, and certainly something during COVID that we are getting more out. And so once we've done some of those shorter term management, we need to kind of think about the long-term management. And this slide might be a little bit intimidating, not only with lots of the writing, but maybe some of these medications that you may or may not have seen. One of the things I'd just like to walk through is a quick snippet of best practices in each of our categories of substances and some of the tools that we do use in terms of pharmacotherapy, because unfortunately, I think because of the stigma, many people might not ever be offered some of the pharmacotherapies that are available to them, along with all the psychosocial supports. And so we are going to walk through the opioids. Again, fentanyl, hydromorph, morphine, codeine, Tylenol 3s, Percocets. Many of these you may be familiar. In any given year, about 20% of Canadians are on an opioid. And again, that's those that are prescribed, not out of illicit markets. So probably many of you are familiar, but here I've included just some trade names and street names in case it's more familiar for certain individuals. But when we think about what is best practice in terms of care for individuals, we know that relapse rate with opioids are quite significant, circa 90 to 95% relapse rates in virtually all literature. So it's really important. And one of the opportunities I had was to sit with the CRISM National Opioid Use Disorder Guidelines. Really, our Canadian guidelines have really meant to be ensuring some of that safety, that people have access to what is the first line treatment of buprenorphine naloxone. Here I've included as Suboxone just because many people have more familiarity with that term, but it is the buprenorphine and naloxone combination. Again, a safer first choice where it's a longer acting partial mu-opioid agonist, provides the stability of the receptors. It helps reduce side effects, helps cravings, withdrawals, and allows people to get connected into all the other parts of the care that they need. Second line being methadone, third, slow release oral morphine. And even within the past year and bit, we have been seeing many novel treatments coming out, including things like injectable hydromorphone, HAT or heroin agonist treatment, more in BC, and some of the implantable injectable buprenorphine formulations, otherwise known as Probuphine and Sublocade. And again, part of what are the recommendations are really not to move to an abstinence only without supports, without harm reduction, without intensive counseling and supports. And so again, because the risks are high, if you can imagine, it takes only about 3 days after people have stopped using their opioid that they lose their tolerance to opioids. And so if they re-engage with opioids after that, the risk of overdose and potentially fatality is quite high. Hence, the importance also of take-home naloxone kits. And certainly when we know during COVID, the accessibility to substances changes, these are really important strategies. When we think about alcohol, classically, there are many abstinence-based models and peer support models that have done a lot of benefit for people over the periods of time. Unfortunately, there are many people that do require more intensive and other approaches to their alcohol use disorder. Alcohol issues on the medical level, the financial level, the economic level, certainly in all of these areas, still being one of our most important substances impacting throughout Canada. And so we need to think about that when we look at our kind of global approach. And so one of the areas where we strongly also advocate is looking at all of the options, and certainly our first line options in terms of pharmacotherapy are things like acamprosate and naltrexone, which have numbers needed to treat similarly to first line medications in diabetes. And so what these medications can do are, again, help manage with things like cravings, the pleasure associated with alcohol consumption, certainly also affecting some of those withdrawal, kind of post-acute withdrawal symptoms like dysphoria, insomnia, some of those tremors. So we might use some of those medications to help address that. Here you'll see I've included other medications that are not necessarily first line, but also adjuncts or other resources that could be utilized, again, pending the assessment and the severity of the alcohol use disorder presenting with the individual in front of us. And again, another program that might be, if all this fails, might be an important approach, and certainly where the individual wants this, are the managed alcohol programs. And again, Ontario has been quite successful with some of these. This is a place where an individual who has a really hard time controlling their alcohol can have alcohol dispensed in intervals, usually of about, an hour and a half. It's about 6 ounces of white wine, and that's distributed again to that individual in a supervised environment where that person can have access to social supports, medical care, and again has been shown to have repercussions in reducing the amounts of interactions with both the emergency services and police services, hence helping to move people into connection with the rest of the care and supports. And again, support, counseling, support, whether it's peer or groups or some of the more established programming that's out there, and harm reduction along the scale are really, really important. I do want to mention briefly about benzodiazepines and the Z drugs, otherwise known as zopiclone and zolpidem, because we often don't talk about these enough, but again are a significant issue here in Canada, where unfortunately you might have heard of Xanax or Restoril, but this is what we term the PAM family. So lorazepam, clonazepam, temazepam, alprazolam, again function very similarly to alcohol in the brain, with the GABA receptors in the frontal portion, do have that ability for respiratory depression, and again in combination, particularly with other substances, pose a lot of risk. And so we really need to do a better job about assessing for these, building those strong therapeutic relationship with individuals to help looking at a long, slow taper, usually months to years. The Ashton Manual has been kind of known as the gold standard that many clinicians follow in managing benzodiazepine use disorder. And so important that we keep that in mind and we review that. And then importantly, and lastly, more in the stimulant category, you yourselves might fall within one of these. Here you see the caffeine from alcohol being injected, and again, nicotine from the cigarettes. These are what are more socially acceptable substances, i.e. people can have smoke breaks, you can have coffee at work. Things might, I would challenge us to be thought about cocaine or meth utilization in the day-to-day functioning. But again, here I'm also sharing you with some of these that are either over the counter, under the table, or prescribed medications. So here you'll see a product that includes some of the nasal decongestion, so the pseudoephedrine derivatives, which are also isolated and utilized in the production of methamphetamines, and again from a product that is used for weight loss and leaning up in terms of bodybuilding, but again having those ephedrine derivatives in them, and which were pulled from the market and not safe due to cardiac arrhythmias and other. And then again here you see two conditions, ADHD and narcolepsy, where some of these medications might be appropriately prescribed, but again all of these could be potentially abused, and something that we need to be reviewing along with the illicit market of cocaine, crack, and methamphetamine. So again, ensuring that we're reviewing that, we're assessing for those, and we're offering to the best of our ability all the supports and care that are required. When we think about the stimulant category, unfortunately, we don't have an agonist or antagonist treatment that can stabilize in the way that, for example, buprenorphine, naloxone, or opiate agonist treatment for opiate use disorder, or naltrexone and acamprosate for alcohol use disorder. So unfortunately, we're left certainly looking and assessing importantly for any of these psychiatric comorbidities, which again, may be someone who's an undiagnosed ADHD, who is overusing stimulants and then develops a stimulant use disorder issue. It could also be someone who has another mental health issue and numbing some of that through their use in stimulants. Some of the changes that we've done here in Manitoba have been to include the olanzapine on formulary from our emergency services to help with some of the short-term stabilization of individuals who are undergoing a psychosis or a significant agitation and aggressivity secondary to their methamphetamine use. And again, in the post-acute withdrawal phases, when we think about methamphetamine compared to other stimulants lasting quite longer in the system, helping to support them as they're coming down from that. Olanzapines and benzodiazepines are certainly medications that we might use for that. Again, when we think about best practices in stimulant use disorder, a really intensive long-term treatment with multiple psychotherapies, supports, and counseling are really important. And again, harm reduction. When we think about methamphetamine, and particularly here in Manitoba, we've been seeing sequelae throughout our province, anywhere from syphilis to congenital syphilis, which really should be non-existent in 2020 in a first world country like Canada. And yet here we are, and we think about the properties of methamphetamine, which is water soluble, mixed, and what we call shakers, mixed along on the street with any type of liquid, which could include, water from the toilet bowl, as an example. And unfortunately, many of these people coming in with infections, not only of the skin, but of the blood and of the heart, i.e. things like infectoendocarditis, cellulitis, sepsis, and abscesses, and then requiring intensive care unit stays and extended stays or valve replacements, and then also importantly, some of these infectious diseases like hepatitis, syphilis, and HIV. And so when we think about the harm reduction associated with that, we need to be inclusive of those thoughts. Again, just quickly about tobacco, so we don't forget about this, like alcohol, still one of our number ones in terms of impacts on cancers and other comorbidities. And so really thinking about What are we doing for offering some of that treatment? There are definitely, again, pharmacotherapies, including the varnocycline or Champex. Certainly when we think about bupropion, as an option, and nicotine replacement therapies, really that we're offering these along with other treatments and social supports and psychotherapies. And if you're not sure about harm reduction strategies, I've included here some connections and links to important ones that exist on either provincial or national levels. And I mean, these can be tips from anything from how to use safer when you do have that supply. So we often recommend people to use together. Well, in the time of COVID, if they're isolated and maybe not able to use with someone else, it's perhaps having virtual means like this where other individuals can be there and visualize to help support or call for help if that person does go down. Use small amounts. Don't go into injecting right away. Try a small portion. Make sure you have a take-home naloxone kit. Those are some of the day-to-day harm reduction tools that we offer in terms of education and adjuncts in offering care. Certainly when we think about the low use risk drinking guidelines for alcohol and also for cannabis, those are important for reminding and educating to reduce some of those harms, making sure we're making those active offers for STBBI testing. And again, really important, a large issue is safe housing. Unfortunately, in Canada, this is something that is still a true issue that we are facing. And so what are we doing to help support individuals and move them into safe housing? And then when we think about some of the psychosocial treatments and management that we offer, the range can be from more intensive in-house residential treatment programming to perhaps a more moderately intense community-based, whether it's through groups, individual one-on-one counseling, or specialized programs like CBT or DBT, as well as peer supports, anywhere from 12-step based to smart recovery to specific programs like Jib Stop for methamphetamine use. So all of these are really important in kind of that plan of care. And again, during COVID, the access to these programs might have changed. And so like we're doing today with virtual means, a lot of these programs have adapted to offer varying degrees of virtual assistance. We've also in our province added some mental health supports with online phone calls and virtual ways to help support people experiencing mental health and substance use during COVID. And again, there also might be restrictions of some of the in-house programming to meet the needs of COVID recommendations as appropriate for time and place in the provinces. And so really, when we think about kind of all of that as a wraparound kind of treatment offering, we really need to think about those key components as the individual assessments, the medications or pharmacotherapy, the counseling and supports, the evidence-based psychotherapies that are being offered, coping skills for individuals, inclusive approaches, and what I term more as that continuum of care, meeting them no matter where they are as they fluctuate with their substance use, certainly in the context of COVID during these uncertain times. And again, the trauma and mental health, as I was sharing with the adverse childhood experiences, looking at how we might offer and support care, ensure we have that trauma-informed lens, and also connecting people to that trauma, but also having that knowledge for the future of how things might impact later down the line. And then again, safe housing, social determinants of health, these core basic needs, if they're not met, unfortunately, people are not going to be able to be compliant with, daily dosing of their buprenorphine, naloxone, or be able to stay longer than 2 days into their detox treatment stage, or once they've had their treatment, go out into the community and go right back into perhaps an abusive situation or an unsafe environment. So we really need to think about all of those components. And I always say when it comes to addictions, really is that in connection. Many people have coined that the opposite of addiction is connection. And I think this is the extra challenge that we're seeing during the times of COVID. And so how can we connect in a meaningful way during times of uncertainty and when we are limited or restricted is really important. And how do we get creative around that? How do we continue our care? How do we help offer choices and help people to make choices that are good for them? And how do we monitor over the long period and keep reassessing during these times? So one of the things that we've adopted during the COVID-19 period in our RAM clinics is continued to remain open for drop-ins. Again, we've applied some of the precautions as directed by our province in terms of social distancing, PPE, personal protective equipment, and whatnot. Certainly, we're also including things like telephone, video conference, telehealth, so that we were minimizing individuals coming in where appropriate. We've included and responded with an on-call service, so that way providers who are presenting with individuals who are connected with RAM or who experiencing substance use challenges can call and receive support as well. So a little bit in the larger system. And then targeting groups and partnerships along with tools such as withdrawal management and intoxication services for communities and healthcare providers. And again, I would highlight that that's particularly important here in Manitoba with some of our isolated First Nations and rural and northern communities. And so these conversations and strategies have been really important and something that have been engaging in a meaningful manner over this last period. And I want to remind us all that while COVID might be a challenge and addictions are a challenge, we do have people that recover, that improve, that achieve their goals. And it's really important that we maintain hope throughout this as a society, as individuals, as care providers, and those suffering from substance use disorder, because as I've been sharing with you, there are resources, there are people who care, and we need to continue to offer that, advocate for more services, and again, move forward with people during their journey. And while I come from the health or medical perspective, really important, again, as I've alluded to earlier, that we have the other components of our society playing part of this. So whether it's the legal, the education, the social services, all of these have a part, even coordination, transportation, as all of these play a part in both from assessing to treatment and along that spectrum. And so we can all be part of breaking down these silos and being part of that solution. And so I think I'm probably right around that time where we can open it up for questions. And just before we do that, I want to thank not only listening and sharing in this important topic today, but also a big thank you to our team at the Addictions Foundation in Manitoba. This is our MOST program, and some of those work in our RAM clinics, and all of those that work not only in addictions care within our province, but across Canada. I know that things have been challenging, and really sometimes it might feel thankless or feel very very challenging and perhaps draining in some ways. Really want to thank you all for the work that you do. And at this point, I think I will turn it back to Nina for moderating some of the questions, if that is appropriate, Nina. And here is some of my contact as well, as if people wish.
Perfect. Thank you so much, Dr. Poulin. This has been very helpful. I've been receiving so many messages left and right. Just everybody's so happy, and it's such an insightful webinar. And again, so many questions coming in right now. Actually, a lot of comments, mostly just saying, love your positive message, great presentation, fantastic webinar, such valuable information. And again, we thank you so much for this. So I have a couple of questions that have come up as well. First one, actually, one of the first ones that came up was, will the recording and PowerPoint be available after the webinar? Which I've actually received a lot of. I've said yes. And yeah, perfect. Just nodding her head. So yes, the recording and PowerPoint will be available after the webinar. Another question that we have in here is, what is the range of costs to establish a rapid access to addiction medicine model, or the estimated cost per patient?
Yeah, and I mean, that's a great question.
I'm just about to go.
Oh, sorry, go ahead. Dr. Ginette? Sorry.
Yeah, do you want me to, sorry, someone was speaking, so I wasn't sure if it was cutting in, but so what I would say is that I don't have a specific number of cost per patient because for multiple reasons, and I'm going to explain a little bit why. So within the RAM model, it is meant to be not an emergent, so people who are undergoing a seizure or an active withdrawal that requires hospitalization, an active psychosis that needs that assessment is a little bit different than someone who might be presenting with a moderate perhaps withdrawal, or is intoxicated, or just requiring that care. Once we've done and we've assessed them, it then gets connected to the pharmacotherapy or other resources, which might include the detox into a treatment program, might include some one-on-one counseling. So the costs of an individual patient are dependent on kind of all of those parts. But what I will say is the RAM clinic itself, and what we have done here in Manitoba, similarly to what they did in Ontario, was they started with a kind of first year where it was rerouting of internal services with a 1.2 million offering for physician remuneration across the province. And subsequent to that, once the evaluation of the services has been occurring, further supports for that has been happening. So I don't have a specific number of that cost. And what I will say, it's often variable because there are many people who require very intensive care and supports directly in the RAM, but then also in all of the adjacent. So they might have follow-ups for 6 months. And then it might be someone who only requires, 1 or 2 appointments, and then they're connected into the care. So it can be quite variable. And again, pending the substance. So something like opiate use disorder requires them to go on to opiate agonist treatment, which they might need to be followed in the RAM clinic for a longer period of time. We do resource or staff our clinics with full-time nursing. We have half-time OA, full-time counseling, and part-time physician services, if that helps. And if this individual who's interested perhaps in knowing more about that, I can also procure their contact information, and I can have them connect with some of our admin and government who can help provide a little bit more in terms of numbers, if that's helpful.
Perfect. I'll make sure to let them know. So is the RAM model, so just reading one of the questions, is the RAM model available in all provinces?
No. The RAM model is not something that has been adopted in necessarily that form. What I would say is that there are provinces who have adopted perhaps programs that are a little bit similar similar or variances of. I know that our government had looked at the successes with the Ontario model. They had started out with about 7 clinics in the Toronto area, and then grew from there substantially over the past 10 years, grossly around that time frame, and have been growing in number, which again reiterates the importance of these models. But what I would also say is RAM needs to function and is only one, or as I term it, one spoke in that wheel of a wheel that's going around. RAM needs to work in adjacent to the rest of the supports and services that are in the province for addictions, for acute care, for primary or chronic care. And so if people are interested, we would absolutely be able to help people in bringing the RAM model to their province if it's not existent. And I know there has been interest, for example, from Saskatchewan about some of these models. And so often we learn from each other, and sometimes we do things a little bit differently. And so we are certainly very happy to share what we've been doing here in Manitoba.
Perfect, thank you. Let's go through a couple more questions. I think somebody's trying to get on. Did somebody have a question? No? Okay. So another question that we have in here is someone is trying to get access to a psychiatric assessment for a client who has experienced long-lasting psychosis. We have a barrier where they're looking for a 3-day clean time. Each previous visit was deemed polysubstance use. Any suggestions on how to get an assessment when the client actively uses?
This is, thank you. Is that, I'm not sure who posed that, but this is a reality that we face today. And if you recall one of the slides where I said it's really challenging us to look differently, I think this is one of the areas where we need to do that. So based on the system that exists in virtually pretty much across Canada, unfortunately, when it comes to making psychiatric diagnosis and assessments, and this is by virtue of diagnostic criteria. So if you recall that DSM-5, they have to be substance-free for a period of time before they can even do that assessment from the psychiatric lens or the psychiatrist lens. Now, often when they come to see us in the addiction world, we know they have mental health and addiction. The chicken or the egg kind of analogy often comes up in that context. The reality is we can just treat one side. So let's just say I treat the addiction, they treat the mental health. Well, if we don't start looking at addressing all of these at the same time, not necessarily making a full diagnosis if it's not appropriate, but managing some of these symptoms, doing good histories, good assessments, getting that collateral, and really changing a bit of our approach. And some of this may be known to people as kind of that co-occurring. We really need to move towards addressing this. And I say, and as I've talked about the RAM model, we are a rapid access to addiction medicine. And yet one of the things that I feel that I do on a daily basis is also rapid access to mental health, although it's not a mental health clinic, as you know, funding and structure is not in that way. But importantly, we need to be addressing both of these parts, or else the individual, or how that translates is the individual just goes from door to door, back and forth and back and forth. And so if you have the ability to engage leaders in your area, wherever that question came from, to start looking how the system is can be a little bit more robust in its approach to change towards that. I think that's really important. I think also if this individual is either a client of yours or a friend of yours or whatnot, if you can be an advocate to help talk about this, because the other misfortune that happens is often those individuals then become labeled difficult individuals, or these repeats, or however you want to term that. And then the problem then lies, they become a little bit more stigmatized. And so I like to challenge those around me and say, well, we need to ensure we get them the right kind of services and the right kind of care. It's not that they are difficult or report or bad. It's really our response needs to be better about that. And so I really think that you might see pockets of areas throughout your province where the approach might be consistent with more co-occurring, others where it might not. You might have to do individual and kind of provincial or regional advocacy to help challenge that. If that's still kind of that philosophy.
Perfect, thank you. I think she said thank you. Thank you for the information.
If she wants to reach out, she can reach out for that as well.
Fantastic.
One-on-one.
Awesome. We have a couple more questions. One of them, again, just a variety of different questions that we have here. Do you feel that social factors such as racism, discrimination, can also be which can also be traumatic, impact mental health addiction? Absolutely.
When we think about some of the, and again, I'm going to come back to that kind of adverse childhood experiences study. That's only one study that started to look at some of the impacts in childhood and how that translated. I still think we have a lot to learn about what are the impacts of the environment kind of in that one bubble, just like we need to learn and engage in more of that. And so when we think about racism and stigma, individuals' confidence, how that helps them in their day-to-day function, can lead to things like, well, I might, I don't feel confident in my life. I feel shameful. I feel this, I feel that, and might change or impact their pattern of substance use. And so really important that we look at all of those when we're considering what the treatment is for those individuals. And so while we don't have a specific study that exists right now about, for example, racism and the outcome in terms of mental health and addictions, we certainly can say that these are important experiences for individuals that do have impacts on their well-being, which can translate often in impacts in their substance use.
Thank you. So we have two more questions. Is that okay, Dr.?
Yeah, no problem.
Perfect. I know we're over the time, but they're just coming in. So another one, is there any consideration for incorporating non-pharmacological pain management treatments of chronic pain, such as physiotherapy, chiropractic, etc.? Chronic pain is often a driver for opioids use.
Great question. So this is certainly something I think it's really important that we kind of all need to kind of step up and advocate for, because the reality is when we think about even the way the system approaches things, not only just from a clinic perspective, but reimbursement from insurances, coverage for access to some of the non-pharmacological things like physiotherapy, chiropractic, I think is what they said. But I would also include things like cognitive behavioral therapy, which do have good impacts in people who have chronic pain. We need to have more accessibility and more affordable accessibility of these things for people to come off. Otherwise, if someone's, for example, on social assistance, by virtue of how the system functions, it's much easier to get remuneration from the pharmacotherapy aspect, maybe not for some of those other components. Or not only just on the social assistance, but also people who might be employed, who have their own private insurances or don't have those and don't have access. We also need to build a little bit more robust programming targeted for chronic pain, because we know that, again, in Canada, about rates for disability have gone up in the mental health and some of the, what I term emotional pain associated with chronic pain or underlying within that chronic pain. And we need to have other tactics. We need to have a more inclusive approach to help with that. And so I think we're starting to hear more. I know particularly I've had allied health such as representative from Chiropractic Association approached me saying, we recognize there's things we want to be part of these solutions. We need to do that and start exploring and challenging ourselves in those ways to help look at what kind of more effective approaches we can utilize. So I think that is a great comment, and I think we really need to improve in that area.
Thank you, Ginette, and thank you again for that comment, that question. Fantastic. And the last question that we have here is, how long does it take to establish a RAM?
Yeah, so we had quite a short turnaround for our RAM. Now, the beauty was we had a team of us that had went out and visited the RAM clinics in Ontario with some of the leaders, Dr. Meldon Kahan as an example. And so we got to see that firsthand experience when we knew that this was kind of what our government was talking about. But then we really started a rollout of our clinics. And so it started within our Winnipeg base, and where we had current expertise already, and we had resources in terms of human resources and operational or logistics, because you need to consider kind of all of these factors. So we had those up and running within the first month. And then, I had physically went out to start all of the other clinics across the province. And that happened over a period of about 3 to 4 months. And so that will all be dependent on the current landscape in your area or in your province in terms of addiction expertise, in terms of nursing, counseling, physical space, policies, procedures. These are all things that, again, some of them have been happening or adapted with time. We've also borrowed a lot from the Ontario Medify RAM model, and so we'd be happy to share ours. Those could also be utilized from Ontario, so people don't need to reinvent the wheel that way. But those would be some of the factors that would influence how quickly one could get a RAM clinic up and going.
Perfect. Thank you. I hope that was able to answer your question. And again, Dr. Poulin is available if you have any questions. If anybody else has any questions, don't hesitate to send me an email. Send Dr. Ginette the email as well. Either or, we can make sure to have that sent over to Dr. Ginette Poulin. And so I think we've covered all the questions. Is there anything else you wanted to cover before we wrap up?
Just wanted to again thank you everyone for your interest and the work that whatever you do in whichever role you play, and really hope to connect with you all in person one day in the hopefully not so distant future.
Fantastic.
And stay COVID safe.
Yes, definitely COVID safe. Thank you, and have a fantastic day, everybody.
Thank you.
Thank you. Bye-bye.